So Metformin. So this is the French lilac. Used for the treatment of the diabetes from the ancient times, contains the begonite, guanidine. First synthetic begonite, Metformin, in 50s, but subsequently banned due to the risk of lactic acidosis. Metformin is a safer congener of the Metformin, introduced in the late 50s. Now the most widely prescribed anti-diabetic drug in the world. And India is one of the countries in the world which have been using the Metformin since its discovery of the Metformin. But in America, it was not available till 2000. 1999, the FDA has given permission to the Metformin. They feared much bigger because of the lactic acidosis or metabolic acidosis and etc. Now all over the world, the most important drug to be used in diabetes is Metformin. Primary action where? Liver. It reduces hepatic glucose output. Exact molecular mechanism is still unclear, but activates the cyclic AMP kinase, that is the fuel sensor of the cell, cyclic AMP, that inhibits the mitochondrial glycerol 3-phosphate dehydrogenase and thereby decreases the hepatic neoglucogenesis. It improves the tissue sensitivity to the insulin, increases the peripheral glucose uptake, so increases the glucose uptake into the muscle and adipose tissue, that is peripheral glucose uptake. Decreases the intestinal absorption of the glucose, like your oligobose. So that will also to some extent acts on the intestines for the reduced absorption also. And additional effects: reduces the appetite, causes weight loss in some individuals. It is not weight gain drug, unlike your sulfonylureas, weight neutral, or sometimes it loses the weight also, and reduces the blood pressure and improves the lipid profile. So what else you require in a diabetic individual? See the actions, beautiful actions of the Metformin. It acts at the level of the liver, reduces the hepatic glucose output, cyclic AMP, which is a fuel sensor of the cell. Not only that, it also acts on the intestines, reduces the appetite, reduces the blood pressure, reduces the body weight in some individuals, and also it improves the lipid profile. So your ABC is tackled, your diabetic part, your blood pressure part, and also your cholesterol part. So that is the reason Metformin is very important drug to be used in the diabetic individual. Here the most important practical point is, don't start the Metformin higher dosages on the day 1. If you start the Metformin 500 milligrams BD or TAD in the day 1, they cause a lot of the gastrointestinal side effects. The most common side effect of the Metformin is gastrointestinal side effects. Your nausea, vomiting, abdominal cramps, loose motions, etc. And once they develop these side effects, they stop using Metformin. Obviously, they know that after taking this Metformin only, they are getting these effects. So what is the ideal thing? Not to have those side effects. Stop that offending drug. So what is that offending drug here is Metformin. But Metformin is one of the important drugs to be used in diabetics. So what is the remedy for that? Remedy is, start with GERD. Everyone say, start the Metformin with lowest possible dose. What is the lowest possible dose? Not 500 mg. Good. 250 is available. Cost is 50 paise or 75 paise or 1 rupee. 250 milligrams. So 250 milligrams, you start the 250 milligrams of the Metformin and slowly train the fellow not to have the side effects of this drug. So I start with 250 mg, take 1 tablet a day after lunch for 3 days or the 5 days, and then 250 milligrams BD, then the 250 milligrams TID, and then slowly can go to 500 milligrams BD or 500 milligrams TID. That is how we have to treat type 2 diabetes. Once you start the Metformin with the higher dosages, they develop the side effects, they stop using Metformin. What will happen when you don't use the Metformin in a type 2 diabetes? Can you control the diabetes? You can't control without metformin in our Indian diabetics because we are having more IR. What is the drug of choice for IR? Metformin. So it's very difficult. So from tomorrow onwards, if you want to start the metformin, don't start at 5 milligrams OD also. For you learners, start with 250 milligrams. Even the 250 milligrams is not available in your government supply, 500 is available, make it off. Make it off. Okay? So that is the most important thing. So none of your patients should stop metformin because of the side effects. Okay? See, that decreases the fasting blood sugar by around 60, reduces HbA1c 1.5. Another beauty of the metformin is maximum HbA1c reduction. Is it low or medium or high HbA1c reduction with metformin? Very high. How much? 1.5 to 2%. No other drug will reduce the HbA1c to this extent except sulfonylureas. Sulfonylureas also will reduce the HbA1c by 1.5 to 2%. Your costliest semaglutide, 333 rupees tablet, that also reduces the HbA1c by 0.8 to 1%. Your SGLT2 inhibitors like dapagliflozin, empagliflozin, earlier it is costing about 100 rupees. That also will reduce by 0.8 to 1%. Your sitagliptin, 100 rupees tablet, earlier, that also will reduce the HbA1c by 0.8 to 1%. Okay, very good drug. Hypoglycemia, is it an hypoglycemic agent? No, it is an anti-hyperglycemic agent. But it causes hypoglycemia if you use with sulfonylureas, if you use with insulin. So as such it is not an hypoglycemic agent, but if you use with sulfonylureas or the insulin, so there may be chances of hypoglycemia because of, not because of the metformin, but because of the sulfonylureas or the insulin therapy. But as a monotherapy, you don't get hypoglycemia. So what is the place in therapy? Metformin is a first line agent for type 2 diabetes as per most guidelines. Also been shown to prevent the progression of the IGT to the diabetes. That is an important point. The person need not be diabetic to start the metformin. What is the earlier stage of the diabetes? Pre-diabetes. So what is the drug of choice in pre-diabetes? Yes, and also metformin. Good. Medical nutrition therapy is the best drug of choice in pre-diabetes. Suppose if you want to use a drug, so which drug will act there? Metformin. That is the reason even for the normal blood sugars also you can use metformin. That's what OBG people do for the PCOD. No one will get hypoglycemia, all the PCOD fellows, even though they are on metformin therapy, because it is not a hypoglycemic agent. Okay. So it is contraindicated. Impaired renal function, that is the very, very important. You should remember number 30 and 60 in metformin GFR. Less than 30 GFR, don't use it. Suppose if the person is taking, stop it. Suppose if the GFR is more than 60, metformin, can you use or not? Use maximum dose. If the GFR is between 30 and the 60, so what to do? Reduce the dose. Am I clear? So remember 30 and 60 of GFR in metformin therapy. Less than 30 GFR, don't use it. Suppose the person is taking it, stop it. If the GFR is more than 60, you can use the normal dose of the metformin. If it is between 30 and the 60, reduce the dose of the metformin. How to get the GFR? So, age of the individual, gender of the individual, and the creatinine levels, you will get the GFR. So don't be up with the creatinine levels. So get the GFR. So that is the true index of your renal function. The CKD is divided into 5 grades according to the GFR only, not according to your creatinine levels. When the GFR is more than 90, CKD grade 1, 60 to 90, grade 2, 30 to 60, grade 3, again divided into A and B, And 15 to 30, grade 4. Less than 15, grade 5. Also called as end stage renal disease. So in all the renal failure people with GFR less than 30, stop it. Heart failure requiring the hospitalization. So all the conditions where there is a chance of hypoxia, don't use the metformin. So heart failure, sepsis, admissions, myocardial infarction, etc. and etc. perioperative period. So don't use metformin. Okay. So situations where there is a chance of hypoxia, like heart failure and other conditions what I have told you, so don't use the metformin. Hepatic insufficiency and alcohol abuse, again don't use the metformin. So what will happen to the alcohol abuse? So the liver will act normally or abnormally? So what will happen? Hypoglycemia. There will be profound hypoglycemia. So in that situations don't use the metformin, because metformin action is where? Liver. How? Cyclic AMP kinase. Okay. So when the liver is at defect, when the person is an alcoholic abusive, so definitely how to don't use the drugs which act exclusively on the liver, like metformin. Use of the contrast materials for the radiological studies. Okay. So again, for the contrast, we will get the creatinine levels. When the creatinine level is more, so definitely have to hydrate the patient and etc. So in the same way, the fellows on the metformin therapy, so likely to have more side effects. Known hypersensitivity to the metformin, that can be there for any drug. Acute or the chronic metabolic acidosis, including the diabetic ketoacidosis. Any acute conditions, don't use the drugs, OHS. In DKA, which OHA you use? Is it sulfonylurea or metformin? Good. In HSS, which OHA you use? No OHA, insulin only. So in all acute conditions, who need admissions in the ICUs, definitely don't use the OHS, and metformin is also one OHA, so don't use it. So this already I told you. Side effects: diarrhea, abdominal discomfort, nausea, metallic taste, anorexia. GI side effects can be minimized by starting with a low dose and gradual up titrating, and by the use of the sustained release preparation. Now the sustained release preparation is also available, glycomet SR or gluformin SR, etc. So they have the limited gastrointestinal side effect, because the drug is not delivered immediately, slowly delivering. So the side effects will be minimal. See the B12 deficiency. So long-term metformin therapy may cause B12 deficiency, especially in the alcoholic individuals. So he is a 52-year-old male, newly diagnosed with type 2 diabetes, BMI 31, fasting 184, PP 246, and A1C 8.9. So what is the working diagnosis? So diabetes and obesity. So it's a case of diabetes. So most probably metabolic syndrome. So they did not mention the other things. So in such cases you have to look for other parameters of the metabolic syndrome. So they did mention the blood pressure here. They got the blood pressure. They did mention about the lipids. So get the lipids. So they did mention about the fatty liver. Look for the fatty liver. Okay. So these are the very important. So they didn't mention about the thyroid. So look for hypothyroidism. Okay. So they didn't mention about the renal functions. So get the renal functions done. Because in all the obese individuals, what is the drug of choice? What drug you are to support to use? Metformin. Of course, the patient can afford injectable semaglutide also can be used right now. So if you want to use the metformin, renal functions are necessary or not? Good. So according to the GFR, you can use the metformin. So that's how we have to go for that. Very good, very good. You are all giving very good answers. What will be your line of management? Role of the simple carbohydrate, what is the role of the complex carbohydrate, what are the foods with low glycemic index, what are the foods with the high glycemic index, what is the role of the oil, what is the role of the salt. So what will be your line of management here? Are you happy with that, or you want to add drug here? Why you should add drug? This is a very, very important point to be known. See, what is this index HbA1c? What is the target HbA1c? What is the difference? So, is the diet alone will reduce that much? Do you want drugs? Which drug? Why? More insulin resistance. So, that should be your logic. Okay? So, here in that way. Suppose affordable candidate, injectable semaglutide. Injectable semaglutide. So, what is the initial dose? 0.25 mg once in a week for 4 weeks, then 0.5 mg once in a week for 4 weeks, then 1 mg once in a week for 4 weeks, then 1.7, then 2.4. Slowly can upgrade. Okay? When would you like to reassess his glycemic control? So dependence it. Dependent. Suppose the patient is asymptomatic, the blood sugar is blood pressure is normal, the lipids are normal, no family history of any complications in him, no family history of any premature cardiac deaths in the family. So you consider this fellow as a diabetic with high blood sugars, not a complicated one. Then once in 2 months or once in 3 months also you can be seen it. On the other hand, a complicated diabetic, so preferably once in a month or once in 2 months. Okay, sulfonylureas. So they are the derivatives of the sulfonamides. What is sulfonamide? Is it diuretic or antibacterial? Okay, antibiotic. Sulfonamides. Mechanism of the action elucidated by the Lowbury in 46. See, earlier sulfonamides the only antibiotics available at that time. Penicillins, sulfonamides. No cephalosporins, no monoceph, no amikacin, etc., etc. They are all only after 80s or the 90s. But in the early 1942 or 50, 60, up to 60 or 70, 80 also, very few antibiotics are available. Out of them is the sulfonamides. Have you heard the Septron, Bactrim DS? Very opportunistic infections in HIV, we use it once in a day. So that is the sulfonamides. So they found that the people who are getting the sulfonamides therapy, their blood sugars also coming down. So then they thought that these sulfonamides had a unique action not only as an antibacterial but also reducing the blood sugars. Then slowly they studied on that hypothesis, and finally they found one product. So that is sulfonylureas. So those people who are getting the allergic reaction to the sulfonamides, we should be very careful in prescribing the sulfonylureas. Some people develop the rash, allergy or itching, etc. to the sulfonylurea therapy. So that means they are allergic to the sulfonamides. So currently available drugs already told you. What is the advantage of the glibenclamide? Longest acting, more hypoglycemia, okay, cheapest, better not to use in the elderly population, better not to use in the renal failure population, better not to use in the cardiac patients, because if they get the hypoglycemia, it will be very prolonged and life threatening. Okay, next one. What about the glipizide? Next one, last bench, next one. What is the advantage? Tell me some point about the glipizide. Shortest acting. Good. See, useful in the CKD population. Good. What about the glycoside? First one. Good. Cardiac friendly. So cardiac remodeling, etc. Then here. Okay. What about the glimepiride? Mostly widely used. A drug is the glibenclamide. Okay. It is not having chronic hypoglycemia. It can be safely used in most of our population. Is the glibenclamide. Okay. So this is the mechanism of the action of the sulfonylureas. You have the sulfonylurea receptors. So when you are using your glimepiride molecule, so what will happen? This glimepiride molecule will go to the beta cell. In the beta cell there is a receptor, security guard is there. That receptor will attract the sulfonylurea molecule. So come, enter into the cell. So once the sulfonylurea enters into the cell, so that makes your ATP more energized. So what happened when the cell gets a lot of the energy? So that closes your potassium channels and opens the calcium channels. Once it opens the calcium channels, what will happen to the insulin? Insulin will be released into the portal circulation. So what will happen once you have the insulin in the molecule in the blood sugars will come down. So this is not glucose dependent. You all people, if you take a sulfonylurea, you are going to get hypoglycemia. If you take 5 tablets or 10 tablets of the sulfonylureas, and you are going to get the hypoglycemia because it is not glucose dependent, glucose independent. Once you take the sulfonylureas, that goes to the beta cells, there will be the receptors, they attract the sulfonylurea into the cell, and in the beta cell gets energized, and then the potassium channels will be closed and calcium channels will open, and then what are all the informed glucose formed, preformed insulin is there, that will be released into circulation, and you will be in the coma and the blood sugars will be low. It is hypoglycemia. And there are some drugs which are not glucose dependent, they are glucose independent like your SGLT2 inhibitors. Whatever amount of SGLT2 you take it, if you have the hyperglycemia, they control. If you have the normoglycemia, they won't cause hypoglycemia. Am I clear? Suppose you take the voglibose, that is not a hypoglycemic agent. You have the hyperglycemia, that will control. If you have the more carbohydrate diet, that will reduce the absorption. Otherwise, won't cause any hypoglycemia. But sulfonylureas are very, very potent hypoglycemic agents because it's not glucose dependent. So these are the duration of the hours. That is the reason we give once in a day or etc. Anti-diabetic efficacy. See the potent anti-diabetic agents. How much percentage HbA1c reduction? So what is the other drug that reduces 1 to 2%? So metformin and sulfonylureas, these two are the very potent hypoglycemic agents. So action is immediate, better taken about 30 minutes before meals. Metformin, before meals or after meals? After meals. Why after meals? It causes gastritis side effects. So once you take the food, the gastric side effects will be reduced. The metformin should be given after food. Whereas here, before food. Why you should go before food? Because it releases insulin. So after taking the food, what will happen to your blood sugars? Increases. So whatever the insulin is there, that will reduce the postprandial hyperglycemia. But the common error is, our people will take the sulfonylurea 1 hour after food, 2 hours of the food. So what will happen to their postprandial blood sugars? Will go up. And what will happen to their blood sugars? Before the food they get hypoglycemia. So to avoid the hypoglycemia, better to give the sulfonylureas before food. Am I clear? Otherwise, when the food is not there, and if you give a sulfonylurea, so they will get the hypoglycemia. So these are the contraindications. Hypersensitivity to the drug, renal insufficiency that already I told you, hepatic insufficiency in all the cirrhotic individuals, liver failures, etc. better. Pregnancy, all drugs are contraindicated except metformin. Other drugs also can be used in the pregnancy. What is the drug? Anyone? Glyburide. You are right. What is glyburide? Glibenclamide. We discussed the glibenclamide. Longest acting, better to avoid in the renal failure, etc. Why it can be given in the pregnancy? Because the drug does not cross the placental barrier. So in Africa and other undeveloped countries, in pregnancy diabetes, The drug of choice is not insulin, glibenclamide and metformin. They keep on using the glibenclamide and metformin in GDMs without any untoward effects. But in India, we use metformin and immediately after that, insulin. Most of my patients I start with the metformin for only 10 days or 15 days if it is a true GDM. What you mean by true GDM? Second half of the pregnancy. Okay, starts with your dietary approach, MND, and also metformin, and if not under good control, start insulin therapy. What is your goals of the blood sugars during pregnancy? First one. What are your goals of the blood sugars in GDM, fasting and postprandial? Less than 90. Very easy to say, but very difficult to reach. 90. Now what are postprandial target? Less than 120 up to 120 last month. Now recent is 110. So those are the targets of your blood sugars in GDM. So fasting should be less than 90. Postprandial should be less than 110. Very easy to say, but very, very difficult to reach those figures. Otherwise, you will have maternal complications and also neonatal complications, macrosomia, neural tube defects, okay, respiratory insufficiency, then neonatal hypoglycemia, hyperbilirubinemia, hypocalcemia, polycythemia. So these are all the risk factors will be there. All these are very, very common in pre-gestational diabetes. What is pre-gestational diabetes? Before second trimester, during the first half of the pregnancy. That is the pre-gestational diabetes. Second half of the pregnancy is the gestational diabetes. So pre-gestational diabetes means diabetic on the first antenatal visit, knowingly or unknowingly. Some people are type 2 diabetics or type 1 diabetes getting into the pregnancy. So they are the known people. But some people know in the first antenatal visit, their blood sugar is, fasting blood sugar is 130, postprandial blood sugar is 240. First antenatal visit. That means what is the inference? It is not gestational. Pre-gestational. That means they are type 2 diabetics earlier, not diagnosed with a strong family history, childhood obesity, etc. Now they are diagnosed as a diabetic during the first antenatal visit. So this is called pre-gestational diabetes. So what is the drug of choice in pre-gestational diabetes? Is it metformin or is it glibenclamide? Good. Not OHS at all. If it is pre-gestational diabetes, on the day one, you have to start insulin, because before the organogenesis, you know what you mean by the organogenesis, in the newborn. So the fetus, your eyes, your liver, your kidney, etc., they start forming between 8 to 12 weeks of the intrauterine life. So 8 to 12 weeks is a very, very important period not to have any congenital malformations. So to avoid those congenital malformations, use insulin only. So in the first antenatal visit, if the person is turned to be a diabetic, so the drug of choice is always insulin. In the second half of the pregnancy, 24th week, 28th week, 29th week, 30th week, the blood sugars are very high. That is gestational diabetes. Okay, then you can start with your medical nutrition therapy for 5 days or for 1 week or 10 days. Then you can start with the metformin for another 5 days or 10 days. Most of the people, they will be good with the MNT and also with the metformin. Still the blood sugars are very high. That means your target of fasting blood sugar is more than 90, or your PP blood sugar is more than 110 in spite of your medical nutrition therapy and the metformin therapy. Then you can start insulin. Am I clear? Okay. So don't miss my GDM class. Okay, at a later time we will have the GDM also. So the type 1 diabetes, what drug you prescribe? Insulin. Any drug, any OHA is contraindicated in type 1 diabetes. Diabetic ketoacidosis, all OHS. Again, sulfuric also. In any acute metabolic complications, avoid these drugs. Side effects. Hypoglycemia is the most important side effect. See, walled agents like glibenclamide can produce the prolonged hypoglycemia because of the long acting. To minimize the risk of the hypoglycemia, start low and step up. See, the diabetes is a chronic disease. Diabetes is an aggressive disease. So don't be hurry in initiating the high amount of the doses on the day 1. So always start the drugs at a lower dose and slowly uptitrate. This is a very important word. Start low and step up. So if you want to use the glimepiride, don't use 4 mg a day. Start with 1 mg or even 0.5 mg is also available. Okay. So at least you can start with the 1 mg. You wait for 1 week or 10 days. And again, if the blood sugars are not under good control, you can go up to the 2 mg, then the 3 mg, then the 4 mg, etc. Weight gain is very important. Is it possible with the sulfurias? Yes. Why? Because of hypoglycemia. What is the most important body signals to the hypoglycemia? Once you are getting the hypoglycemia, what will give the signals to the body? More to avoid hypoglycemia. So these people will have palpitation, will have sweating, will want to eat more to avoid hypoglycemia. So once they take more food, the calorie intake will be more and they gain weight. So this weight gain is because of the hypoglycemia. Okay. Hypersensitivity reactions, Stevens-Johnson syndrome. Your sulfonamides will cause Stevens-Johnson. Some individuals also will cause Stevens-Johnson syndromes. Secretagogues. What is the drug? Good. Artho start out there. Repaglinide. What is the dose? Good. 0.5 mg and 1 mg is available. Is it control fasting hyperglycemia or postprandial hyperglycemia? Postprandial hyperglycemia. Is it due before food or after food? Before, because they are sulfonylureas. So sulfonylureas should be given before food. So is it a potent drug or mild drug? Mild drug, because it reduces only postprandial hyperglycemia. See the A1C reduction, 0.5 to 1%, not even a 1%, maybe 0.7 0.8%. Main effects on the FPG, particularly natiglinide. Usually who show the marked postprandial excretion of glucose while maintaining the normal FPG. Daily dose repaglinide, okay. I stop here.